I'm going to focus on an area that I've been very interested in terms of mechanical support, which I really feel is the Achilles heel of the second generation VADs and some of the third. And it's the problem of VAD thrombosis. I wrote a review on this topic a couple of years back. I'm going to give you some of the stuff that was included in that review and also update about what is going on with this problem. Sure, anybody want this review article, feel free to email me. My email's on there. I'll be happy to do it. But I think I titled it appropriately then, and I think it's still a title that is apt. A riddle wrapped in a mystery inside an enigma. The early VAD experience with pump thrombosis was fairly unremarkable. In the early years of 2000, the rates were fairly low. We have a couple of ways of looking at it. One way of looking at it is the events per patient year was less than 0.03, which is a very low rate, and in fact wasn't remarked upon by anybody in the first decade of this century. More recently, what provoked all the controversy was in early 2014, 3 studies were published within that same month. 2 were in the Journal of Heart and Lung Transplantation, and 1 was in the New England Journal of Medicine. I'm going to go through each of these sequentially and give you the gist of what they found. The first article was on the hardware device, where it was noted there was increased pump thrombosis rate. In this picture, you have A and B. On the left was the original version of the hardware that was a highly polished metal surface. On the right has a base of sintered titanium that you can see. And I'll explain why the design was changed. This is the same type of sintered titanium that have been seen in the HeartMate devices. There were close to 400 patients in the Bridge to Transplant trial. 34 pump thrombosis events occurred in 31 patients. And what happened with this group is that we saw a doubling of the events per patient year in this trial. And the group that published the paper divided the thrombus patients from the non-thrombus patients and tried to stratify why thrombosis was occurring. Wasn't quite clear. They did find some risk factors, but they found enough events in the patients that had the non-sintered HVAD that they switched the design. Now, the beauty of a sintered titanium is it's almost counterintuitive. You have the sintering to promote adhesion of circulating cells in the blood to then form a pseudo-intima. And what the pseudo-intima does, and you see a photomicrograph of it on the right side, it actually acts as a buffer that prevents the ingrowth of thrombus into the inlet of the VAD. It kind of functions like the Denver Broncos defensive line. I mean, if you see the pictures here on the left, you see thrombus encroaching upon the orifice of the inlet. Here, nothing gets past the pseudo-intima. And when they analyzed the data, they found that the risk factors for the pump thrombosis were on being on little or no aspirin, an INR that was less than 2, patients who were less emergent, who had higher INTERMACS profiles, were also more likely to have pump thrombosis, and those patients that had higher MAPs while on a device also were more prone. And there are a variety of reasons that were conjectured. The aspirin and INR were easy to figure out. The less sick patient profiles were used because these patients were less likely to be on aspirin because of how ill they were or how they had contraindications. Finally, the MAP was felt to result in lower RPMs and pump flow rates, and that might have contributed to the pump thrombosis problem, but these were all conjecture. As a result of those factors, though, there were protocol changes in the HVAD trial, which resulted in a lowering of the incidence. The second article by Starling, originating from the Cleveland Clinic, reported on 3 centers that were high-volume centers and their experience with the HeartMate II. And what they found are nearly identical incidences of pump thrombosis that started to go up in 2011. and went up quite a bit, as you can see. In the early years, the pump thrombosis rates were fairly low, as I've already shown, and then they all rose at each of these centers, which included the clinic, Wash U, and Duke. And what they found was that when they analyzed the data, in most of these patients that developed pump thrombosis, the LDH went sky high and started rising about a month before the pump thrombosis occurred. And they also found that the management of the patients was very important in determining the outcome. Those patients that were managed conservatively with medical therapy alone were much more likely to die than those that underwent emergent heart transplantation or replacement of the device. The final paper was by Kirkland et al. Based on the INTERMACS database. And in looking at the database, they found in the years from 2009 to 2012 that there was a 6-fold increase in pump thrombosis by 1 year. And the risk factors for pump thrombosis were as iterated in this table. Implant year, obviously the later, which was the subject of the paper, younger age, white race, larger BMI, better EF, and higher LDH at 1 month after surgery. The MAUD database, which the FDA runs, that includes all post-market surveillance of device complications, showed also quite a big rise, an over 400% rise in LVAD thrombosis, and the MAUD database has it occurring a little bit earlier, that actually had an inflection point about a year earlier than the papers I've previously cited. This was all obviously very concerning. What we've seen is that there was a definite increase in the thrombosis rate, markedly. The LDH looks like it predicts thrombosis in a large proportion of patients and might signal the point at which we should get much more aggressive with maneuvers like increasing the anticoagulation, antiplatelet therapy, perhaps trying to get the RPMs up. The thrombosis rate was occurring earlier than before, particularly for the HeartMate device. The thrombosis, if a patient developed thrombosis, it was associated with worse outcomes, even those that had VAD replacement. The outcomes appear to be better with device exchange over medical therapy, and that's been borne out over time. In analyzing what could be causing this increase, it was really quite perplexing. Did the thrombus originate proximal to the pump body? And did it extend and then embolize? Did it originate in the pump? Or did it occur in the outflow and propagate proximally? It wasn't quite clear. There's what I call a yin-yang of pump speed that we've been struggling with for those of us who have been putting in the pumps. There are things that drive us to lower the pump speed and things that drive us to up it. With a lower pump speed, you're less likely to have a suction event early post-op. You're less likely to have RV dysfunction from septal shift. You're more likely to encourage greater pulsatility because you're not emptying the ventricle as much. And therefore, you're also more likely to have aortic valve opening. And perhaps that translates over time to a lower incidence of GI bleeding because of the greater pulsatility. On the other hand, a higher pump speed gives you a greater effective cardiac output and blood pressure. You also have better washout and heat dissipation of the pump rotor. But you also have more LV stasis because the ventricle is being emptied more effectively. So which was more important and how did this play into the problem that we were seeing with the pump thrombosis? It's still not quite clear. The Journal of Heart, Lung, and Transplantation published a few years back how these factors interrelate and how we should proceed in thinking about them and addressing them. This is a complex diagram, but what it does is it shows the way we should address problems that may presage pump thrombosis from less aggressive to more aggressive from left to right. So you have power elevations and their workup, an isolated LDH rise, evidence of hemolysis, and new CHF symptoms. Device replacement is fairly easy if you do it the minimally invasive way, meaning you don't replace all the pump parts. Here there's an assumption that the primary problem is in the pump body, and this will obviously not correct for an inflow problem or an outflow problem. But the way you do this is through an incision in the mid-epigastrium, and you can use various retractor devices to expose quite nicely the pump body, and you extract it. And Dr. Frazier and Dr. Gonzalez have published lesser invasive approaches and leaving more material inside the patient. I'm not sure what the most appropriate way to manage it is, but it also worries us some that we may be leaving a problem behind. And one thing that we've seen over time is that once you replace a pump once, you're more likely to replace another pump in the future. And the cost is obviously enormous. Since we published that paper, there's been updates that have occurred over the last couple of years that I want to provide you. In more recent publications, the LVAD thrombosis rates appear to have improved and plateaued, but they haven't returned to the pre-2011 rates. The probability of recurrent thrombosis is progressively higher with each pump exchange, which I've just alluded to. Each thrombosis event confers an additional risk of morbidity and death. As I just mentioned, the isolated pump exchanges may not be taking care of the entire problem. The greatest hazard for thrombosis is generally early, within the first 3 to 6 months of implant. Subtherapeutic or inadequate anticoagulation have definite causal links to thrombosis. And yet there is no clear explanation as to why the thrombosis rates initially rose and why they're getting better. There are some guesses. One guess is that possibly there's a Hawthorne effect. A Hawthorne effect is when you're being scrutinized or as part of a study, you try to make things better. And one thing that many of us have been doing is using higher pump speeds to encourage higher flow through the VAD. We've become much more aggressive about anticoagulation. Many of us have abandoned heparin bridging in the early years because of the prohibitive re-exploration rates we experienced. Well, we went back and revisited this. Also, we started monitoring LDH levels more scrupulously, and we applied aggressive anticoagulation in earlier periods of time than we would have otherwise. In August 2015, last year, about a year ago, the FDA issued a safety communication on adverse events in LVADs and included the mention of thrombosis in HeartMate II, stroke in the HVAD, and bleeding with both devices. At this point, caution should be observed in extending this therapy to the lesser severely ill. Those of us who had great enthusiasm about operating on patients earlier on in the heart failure trajectory are now a bit more cautious. In 2015, the Revive It trial, which was extending this therapy to earlier patients, was put on hold, and I'm not sure if that's ever been revived. Maybe someone can share that with us who knows. The PREVENT study was just recently presented at ISHLt. PREVENT was a trial that Thoratec, now St. Jude, enrolled patients in that made a standardized approach to implantation, anticoagulation, antiplatelet management, and pump management. And in this trial, the HeartMate II thrombosis rates were more than halved by this approach, which was very encouraging. In looking to the future, I think we're still going to have problems with pump thrombosis in the second generation VADs, but there's hope for the third generation. The good news coming out of Europe is the HeartMate III trial. In the first 50 implants, survival was similar to the HeartMate II at 1 year of 80%, but there were absolutely no pump thromboses. And this may be related to the maglev technology that we've just heard about. And this maglev technology may be the important factor that allows us to get beyond this Achilles heel. So in summary, VAD thrombosis is a threatening and complex problem. Its etiology is likely multifactorial. Some management changes make sense, and these were corroborated in the trial that St. Jude conducted. Biweekly serial monitoring of LDH in patients after LVAD is probably prudent to try to pick up on these patients early. The algorithm devised by ISHLt should be followed and used as a guide in managing the patients. If the patient is in shock, a decision needs to be made regarding emergency surgery, or in the case of non-candidates, last-ditch thrombolytics. Surgery really should be a first-line therapy for patients that have definite thrombosis because of the much better outcomes. And remember, VAD therapy is the best thing to happen to advanced heart failure patients since heart transplantation. And there's hope for the future. Although more recent data indicating a plateau of the pump thrombosis rates for the second generation, rates still remain unacceptably high. 1 in 10 HeartMate II patients and 1 in 13 hardware patients can be expected to experience pump thrombosis. This fact needs to be explained to patients in consenting for the procedure with these devices. The early news from studies with the next generation looks very optimistic, but we should be, again, cautious. Thank you.